This is part 4 of our module Drugs Acting on the Cardiovascular System, specifically Antiarrhythmic Agents, which is chapter 45 of our reference book. For the learning objectives, upon completion of this chapter, future nurses will be able to describe the cardiac action potential and its phases, to explain the changes made by each class of antiarrhythmic agents, describe the therapeutic actions, indications, pharmacokinetics, contraindications and cautions, most common adverse reactions, and important drug-to-drug interactions associated with antiarrhythmic agents, discuss the use of antiarrhythmic agents across the lifespan, compare and contrast the prototype antiarrhythmic drugs lidocaine, propranolol, sotalol, and diltiazem with other agents in their class and with other classes of antiarrhythmics. Outline the nursing considerations, including important teaching points for patients receiving antiarrhythmic agents. As discussed in earlier part of this module, disruptions in impulse formation and in the conduction of impulses through the myocardium are called arrhythmias. They also are called dysrhythmias by some healthcare providers. Arrhythmias occur in the heart because all of the cells of the heart possess the property of automaticity, which will be discussed later in this chapter, and therefore can generate an excitatory impulse. Disruptions in the normal rhythm of the heart can interfere with myocardial contractions and affect the cardiac output, the amount of blood pumped with its beat. Arrhythmias that seriously disrupt cardiac output can be fatal. Drugs used to treat arrhythmias, called antiarrhythmics, suppress automaticity or alter the conductivity of the heart. So these arrhythmias involve changes to automaticity or conductivity of the heart cells. Changes can result from electrolyte imbalance that alter the action potential, decrease oxygen delivery to cells that changes their action potential, structural damage that changes conduction pathway, or acidosis or waste product accumulation that alters the action potential. In some cases, changes to the heart's automaticity or conductivity may result from drugs that alter the action potential or cardiac conduction. We now go to conductivity. With normal heart function, each cycle of cardiac contraction and relaxation is controlled by impulses arising spontaneously in the sinoatrial or SE node and transmitted via a specialized conducting system to activate all parts of the heart muscles almost simultaneously. These continuous rhythmic contractions are controlled by the heart itself. This property allows the heart to beat as long as it has enough nutrients and oxygen to survive, regardless of the status of the rest of the body. We will take a closer look to automaticity. All cardiac cells possess some degree of automaticity, as discussed in chapter 42, in which the cells undergo spontaneous depolarization during diastole or rest because they decrease the flow of potassium ions out of the cell and probably leak sodium into the cell, causing an action potential. The action potential of the cardiac cells consists of 5 phases. So we have phase 0 that occurs when cell reaches a point of stimulation. Sodium gates open along cell membrane and sodium rushes into cell. This positive flow of electrons into cell results in an electrical potential called depolarization. So there is no charge difference between inside and outside of membrane at this phase. Phase 1 is a very short period during which the sodium ion concentration equalizes inside and outside of the cell. Phase 2 or plateau stage occurs as the cell membrane becomes less permeable to sodium and calcium slowly enters the cell and potassium begins to leave the cell. Cell membrane is trying to return to its resting state, a process called repolarization. Phase 3 is a time of rapid repolarization as the sodium gates are closed and potassium flows out of the cell. And phase 4 occurs when the cell comes to rest. The sodium-potassium pump returns the membrane to its resting membrane potential and spontaneous depolarization begins again. So each area of the heart has a slightly different appearing action potential that reflects the complexity of the cells in that area. Because of these differences in the action potential, each area of the heart has a slightly different rate of rhythmicity. The SE node generates an impulse about 60 to 100 times per minute. The atrioventricular or AV node about 40 to 50 times per minute, and the complex ventricular muscle cell about 10 to 20 times per minute. We will now move on to hemodynamics, which is the study of focus that move blood throughout the cardiovascular system. Hemodynamic alterations cause serious complications like lack of sufficient blood flow to the brain that causes syncope or precipitate stroke, lack of sufficient blood flow to the myocardium which can exacerbate atherosclerosis and cause angina or myocardial infarction. So we have types of arrhythmias. We have tachycardia, bradycardia, premature atrial contractions or premature ventricular contractions, atrial flutter, atrial fibrillation, which were already discussed in chapter 42. So figure 45.2 shown in the slide is an ECG that shows normal sinus rhythm. So here's some ECG results showing the different arrhythmias. I will leave it up to you to look closer. Okay. We will now continue with antiarrhythmic agents. Antiarrhythmics affect the action potential of the cardiac cells by altering their automaticity, conductivity, or both. Because of this effect, antiarrhythmic drugs can also produce new arrhythmias. That is, they are pro-arrhythmic. Antiarrhythmics are used in emergency situations when the hemodynamics arising from the patient's arrhythmia are severe and could potentially be fatal. It was found that antiarrhythmics may block some reflex arrhythmias that help to keep the cardiovascular system in balance, or they may precipitate new deadly arrhythmias. Therefore, it is important to document the arrhythmia being treated and the rationale for the treatment and to monitor a patient regularly when using these drugs. So as reflected in the slide, we have class 1 antiarrhythmics, which are drugs that block the sodium channels in the cell membrane during an action potential. So these drugs are further broken down into 3 subclasses reflecting manner in which their blockage of sodium channels affect the action potential. So these subclasses include the following: class 1 antiarrhythmics like Norpace, Pronistil, and quinidine. Class 1B, so we have there actually class 1A 1B, like lidocaine and mexilitin. And then we also have class 1C antiarrhythmics like Tambocor and Retmol. So for the rest, okay, kindly go over them closer when you get your PLP copy. Okay, so we have there type 1B and 1C, and then the class 2 antiarrhythmics. Then we also have the class 3, class 4, and other antiarrhythmics. So we have here also a copy of the drug therapy across the lifespan. And then the therapeutic actions, indications, and etc. for class 1 antiarrhythmics. So I would just like to make mention that class 1A drugs depress phase 0 of the action potential and prolong the duration of the action potential. Class 1B drugs depress phase 0 somewhat and actually shorten the duration of the action potential. Class 1C drugs markedly depress phase 0 with a resultant extreme slowing of conduction but have little effect on the duration of the action potential. So these drugs are local anesthetics or membrane stabilizing agents. They bind more quickly to sodium channels and are open or inactive ones that have been stimulated and are not yet repolarized. So this characteristic makes these drugs preferable in conditions such as tachycardia in which the sodium gates are opened frequently. Then we also have class 2 antiarrhythmics, which are beta-adrenergic blockers that block beta receptors, causing a depression of phase 4 of the action potential. So several beta-adrenergic blockers such as Sectral, Brivibloc, and Propanolol or Endiral are used as anti-arrhythmics. So I also would like to make mention that under the adverse effects associated with this class 2 antiarrhythmics, no, they are usually related to the effects of blocking beta blockers in the sympathetic nervous system. So we also have the class 3, which include Cordaron, Tecousin, Corvette, and Betapase. And the adverse effects of these drugs are those that are associated or related to changes they cause in the action potentials. Then we also have class 4, which include 2 calcium channels or channel blockers. And then the nursing considerations, diagnosis, and planning for antiarrhythmic agents. And then we also have implementation with rationale. And then the types of arrhythmias and drugs of choice for treatment. So just kindly go over them closely when you grab a copy of your PLP. So that's all for this chapter, and thank you for your attention.